Hello and welcome to Best of the Day. I'm Dr. Christy Russell from the University of Southern California, and I'm here at San Antonio at the 2013 San Antonio Breast Cancer Symposium. During the time that I'm here, I have 4 different interviews with some thought leaders in the field of breast cancer, and I'm asking them to be interviewed on different topics that have been presented here in San Antonio, including surgical issues, HER2 positive, hormone receptor positive, and fortunately for me and for you, I've asked Dr. Joyce O'Shaughnessy to discuss the issues around chemotherapy, triple negative, and sort of an overall issue of things that were not included in the other topics. So thank you for joining me, Joyce.
Happy to be here, Christy.
Fantastic.
Thank you.
So today we heard a somewhat eclectic group of presentations, but there are some consistent themes. The first was a presentation by William Sykoff from the Alliance Group, and they did a study looking at the addition of carboplatin or bevacizumab or the combination in with standard neoadjuvant therapy for women with triple-negative breast cancer. Can you walk me through that trial and what they found?
Sure. It was a trial that focused, as you said, on triple-negative, defined as less than 10% ER/PR positive, HER2 negative, and everybody got 12 weeks of weekly paclitaxel, 80 per meter times 12, followed by Dosedense AC, and I think it could be actually every 2 or every 3 weeks. And then they were randomized to receive the carboplatin AUC of 6 every 3 weeks times 4, along with the weekly paclitaxel. And then there was another randomization of plus minus bevacizumab. They got 9 doses of bev with the weekly paclitaxel, and then partially overlapping the AC so they could stop and go to surgery. Primary endpoint was pathologic complete response in the breast, but then they also did a secondary analysis in the lymph nodes and breast. And what they found was that there was a modest improvement in pathologic complete response rate, about 10% or so, with the addition of bev. But unfortunately, the risks of bev basically neutralized the benefits. You know, there was the hypertension, a couple of GI perforations, some bleeding, more febrile neutropenia. So that kind of neutralized that there. So there was a consensus that should not be a way forward. And then with the platinum, with the carboplatin, looking at breast and axilla, which will allow us to then compare it to a subsequent study by Hope Rugo and the I-SPY 2 network, taking out the bev now, just looking at the plus minus carboplatin, the pathological complete response rate, breast and axilla, without the carbo went from 39% to 49%. So a 10% improvement looking at breast and axilla. Of course, they're going to be looking at a lot of biomarkers to find the basals and the BRCAs and all that stuff. We don't have that at this moment. It's a small, very small. No, that one was that was pretty good. 600 something patients. And unlikely they'll have enough, data down the road for a really good look at disease-free survival. Although I think they're planning that'll be a little while, but nothing presented today. Now going on then to the presentation that came immediately thereafter.
So the one that immediately after, Hope Rugo presented on half of the I-SPY 2 trialists.
Yes, yes.
And before you get those results, can you try to summarize the way the I-SPY 2 trials are being run?
It's a really neat thing, I must say. It's highly innovative. It's a neat thing. Basically, they're breaking down the breast cancers into 10 subtypes, and it's based on ER, HER2, and whether you're mammaprint high or mammaprint very high. You can't be on these preoperative studies if you're mammaprint low, which is great. And all the different permutations, of triple negative, HER2 positive or negative, ER positive or negative, mammaprint high or very high. And this way they can see where the path CRs are developing. So what they're doing is, it's 9 different agents, I believe, they can look at any one time. But let's just, for simplicity, take the backbone is weekly paclitaxel followed by AC. That's their backbone. And it's plus minus new agent with the paclitaxel. And the issue is, does it work in ER positive? Does it work in HER2 positive? And if you're HER2 positive, of course, you get the trastuzumab. And it's adaptively changed so that if there's very few path CRs, shaping up in your ER positive group, for example, the number of patients randomized into that cohort diminishes, and then when they get to a certain number, if they are below the threshold that they would need, that basically closes, and they focus in on more accrual to the triple negative, let's say. In this case, that's what's happened, and they get to a certain number where statistically, Don Barry says, we now have enough patients in these two plus minus, in this case, carboplatin, veliparib. We have enough numbers, even though they're not that big, that we can predict that based on this delta on PAFCR, that if you went forward into a 300-woman phase 3, which isn't that big, preoperatively you'd have a over 90% chance, 92% or whatever it was, chance of having a positive study with a delta on your PAFCR that would be of clinical interest to be able to lead to FDA approval, basically. Right. Fascinating. It was all adaptive, and then so the women who were subsequently enrolled in the study have learned on the women who have already enrolled, and it's not just based on PAFCRs, it's also they look at MRIs along the way to see if there's some improvement, because it's obviously, if it's good early on, then you can use that information sooner than later. Fascinating. So it's really good because it's decreasing the number of women that we're exposing to these agents and such. So what we heard about today was the first results of the I-SPY 2. Very good. Lovely, presented by Dr. Hope Rugo. Weekly paclitaxel followed by AC, and in the CLGB it was Dosedense. This was either Q2 or Q3, I believe, was the option. With or without 2 additional drugs added, the carboplatin, AUC of 6 every 3 weeks again, with oral veliparib, and veliparib is a oral PARP inhibitor. And basically, if I was doing my math correctly, I think they were getting down into the range of, with the adaptive design, I think they were down around 60, 65 patients. I could be wrong, it wasn't clear, but doing the math from what Hope said, about 60, 65 patients in the triple negative, because it turned out that veliparib carbo, interestingly, added 0 to the hormone receptor positive, which is a helpful information. And so they basically showed the PAFCR rate in breast and axilla with the weekly paclitaxel followed by the AC was 26% and doubled up to 52% with the addition of the carbo and the veliparib. And of course, there was a bit more toxicity with the carbo veliparib, as you'd expect, but it was manageable. They got it in there pretty well. So that graduated to it's going to go into a phase 3 trial now. If you look at the veliparib carbo Taxol AC, PAFCR at 52%, and compare that to the William Sykoff trial where you take out the BEV and you're looking at breast and axilla, and you're looking at weekly paclitaxel carbo followed by the AC, that's 49%. That's the same number. And so Dr. Puzdai, who gave the discussion, said, it would suggest that the benefit of veliparib is either 0 to modest, but it's cross-trial comparisons, et cetera. So the question, of course, is it the carbo, is it the veliparib? Now, the 26% PAFCR rate with weekly paclitaxel followed by AC is on the lower end. Of course, the confidence intervals are going to be wide, around a relatively small number. In the CLGB study, which is much larger, be right what we'd expect, right about 39%. So we're probably, in truth, looking at a delta of about 10%. And we don't have any systemic data, no disease-free survival data. So is a 10% difference in an unselected triple-negative population enough to change the standard of care?
So a couple questions. One is, this is carboplatin. And a lot of the data behind this was the use of cisplatin in patients who were known to be BRCA positive and very high pathologic complete response rates. We've done a switch over to carbo, which in some diseases is not as good as cisplatin, and I'm not sure we know the effect of carboplatin in the BRCA population in the neoadjuvant setting.
Not that I've seen data on, Christy.
So, the presumption is that the platinum was added here because a lot of basal breast cancers, some may be BRCA positive, some may have similar biologic defects similar to the BRCA population. And both of these studies do have pathology, and we'll be looking at BRCA mutations and other mutations that hopefully we can correlate with the benefit of carbo. In the meantime, what do you do?
So the TCGA showed that in the basal triple negatives, they were very similar genomically to ovarian cancer. My understanding, not being an ovarian cancer doc, is that carbo and cis are considered the same in ovary. That may not be true in non-small cell, et cetera. But so I have pretty good equipoise. Okay. I will say when I'm treating a known BRCA1 germline mutation, I'm going towards cis. Okay. So what have I been doing? And I don't think it's going to change on Monday morning with these data. First of all, I actually think it's important to start with AC, my opinion. When you've got a basal breast cancer with very high proliferation, you know you've got a homologous recombination defect. I think you got to get your DNA damaging agents in early. Now, of course, if you start with weekly paclitaxel carbo, you're accomplishing
Correct.
that.
Right.
You know?
Right.
But do we need 4 drugs? Do we need the toxicity of 4 drugs versus 3? I think it's an important question. Mm-hmm. You're going to pick up more leukemia with more DNA damaging agents. You know, so I'm going to stick with AC up front, dose dense. I monitor that. That is my barometer. Is this woman got the chemotherapy sensitive or resistant breast cancer? If she's done well with the AC, I usually go on then to Dosedense Taxol. If she's very high risk, Christy, even before these data, I've been adding in carboplatin. If she's multiple nodes positive, the kind on the PET there's subpectoral and all. I have been adding in the carboplatin in that patient.
But have you been adding it in pre-op or post-op?
That pre-op. That pre-op in that particular group pre-op.
Okay.
If a woman, however, has had a clinical CR after AC, which we all know a lot do.
Right.
I go on to Taxol, dose dense Taxol. Then I go to, obviously, surgery. If she's a past CR, she's done. If she's had that beautiful response of a clinical CR to AC and she still has residual disease, I run the RCB. If she's RCB 0, or not 0, but 1, she's done. The data are very convincing that I think, and it's been corroborated, that you do well. But if she's an RCB 2 or 3, and I've got documentation she had chemotherapy sensitive disease, I'm giving her platinum postoperatively. Now I've been using cisplatin. Based on these data now, I'd be comfortable using carboplatin. So for the high risk patient, I may just bring it in I'll probably still start with the AC. With the AC. I'm not convinced that 52% is such a big difference. And the thing is, Christy, we have to look carefully at these data. Starting with the weekly paclitaxel, there were more progressions, and we have to look at that. Probably the carbo, ameliorated that.
Right.
But the thing is, I'm not quite ready to start using 4 drugs on everybody. I'm just not quite ready for that, So I'm going to stick with the AC, at least as I've thought it through so far. I'll probably stick with the dose-dense AC, go on to the Taxol, bringing in the carbo for the high-risk population. But if she's a clinical CR after AC, I think I'll go ahead and give her Taxol. And now I will say that, and if I have, even today, if I have a low-risk BRCA, small cancer, she's clinically node negative, the PET up front looks good, I've not been using platinum unless she's a no-path CR.
Okay.
If I have a node-positive BRCA, I've been utilizing the carbo along with the Taxol. I've been doing AC followed by the Taxol carbo there, just because she's high risk, and I know I'm going to want her to have that platinum.
Okay.
So I have a little bit of a mishmash depending on a number of factors.
So it sounds like some of these 2 trials are beginning to support your standard of care.
Right. And let's make one more point on that study that we visited about Alba et al., 2012 Annals of Oncology. It was a trial, I believe it was about 60 patients in each arm. They focused on triple negative, but they went further than that and tried to select the basals based on IHC, either EGFR positive or cytokeratin 5/6 positive. Really very nice.
Right.
And they randomized them to upfront EC times 4, Epi 90, Cytoxan 600, very acceptable, times 4, followed by the Taxol, with or without the carboplatin, and the carbo was AUC of 6 every 3 weeks times 4, and the PAF CR rate was 35% with the standard EC followed by Taxol 35 and versus 30% with the addition of the carbo. There wasn't a hint of benefit. That doesn't surprise me. AC are very good DNA damaging agents. And now let's see, let's think of those numbers there. They're a little on the lower side, you know. But I guess if that's going to boil down to how many T2s you've got, you know, and how many clinical N0s you've got, what your disease volume is there.
Right. But you have, you know, yes, if you're going to give all drugs, Joyce, does it matter that you're giving the taxanes first? Or you're saying that you're going to gather so many people with the AC that the carbo doesn't really matter afterwards. And so what you're suggesting is that if you're giving the Taxol up front, you're losing patients to progression. And so the carbo does matter if you give it up front.
If you're giving the Taxol up front,
right.
I think these data definitely would suggest you should add the platinum.
Okay.
Yeah, I would definitely say that because I have to look at those numbers on the slides, but they were losing some patients. They were having more progressions, as we would expect with these really, you know, aggressive basals, some of which, you know, respond great to Taxol. But starting with just one agent, you know, in that aggressive biology appeared not to necessarily be 100% the perfect way to go based on the progressions. That's an important consideration for the I-SPY, I think, to take a look at who progressed and see if there's something that can be done, you know, about that, and perhaps platinum in those patients should be a standard, or they're still probably wanting the opportunity to put a plus-minus new agent in there for those patients. So
more to come on the platinum story for triple-negative breast cancer. Much more to come. There's an Italian trial that was then presented by Dr. Cognetti, lots of Italian names with beautiful accents. And it was a trial that, a very large phase 3 randomized trial. When I first sat there and listened to this, I thought, boy, this is not that interesting. We've already proven this, but there are a couple points on this I think that we could all learn from. So it was a huge phase 3 randomized trial. Why don't you walk us through that trial?
It was a 2x2 factorial, so there were 2 randomizations. One was to EC versus FEC. Good dose is 90 per meter, and the FEC was 600, 90, 600. So a decent dose of 5FU, but just on day 1, not day 1, day 8. So EC versus FEC, first randomization, and then the patients received paclitaxel, Taxol afterwards at 175, and the randomization for the whole study was every 2 weekly versus every 3 weekly. So both the EC and the FEC were also randomized to a Q2 versus Q3, and then the Taxol was Q2 versus Q3, and the Q2 weekly patients received pegfilgrastim. So there was no difference between the EC and the FEC, but the Dosedense schedule had a superior disease-free and overall survival advantage. It was more impressive in the ER-negative population with the hazard ratio for disease-free survival of 0.67, but in the hormone receptor positive, it was still significant at 0.80. So we kind of knew that about the Taxol. If you're going to give Taxol 175, give it every 2 weeks. So that wasn't new news. But the discussion was going on about, okay, 5FU is dead. We shouldn't be using any FEC or FAC. We don't need it. We should just stick with that EC or the AC. But I do want to say that, you know, the MD Anderson has been using FAC for a long time, 550, 500. And so they have a lot of data with that, and their, you know, overall disease-free survival results are comparable to what we see with an AC Taxol regimen. And the issue is, in this day and age, when I don't know, particularly in ER-positive breast cancer, whether the adriamycin is necessary at all. And until we have the results of the now closed NSABP B49 trial of 6TC versus AC followed by T, which will be a couple of years, I'm a FAC fan. I'm not saying it's going to be better than AC, but I am saying it's less adriamycin.
Okay.
And I like that. Exceedingly well tolerated, no pegfilgrastim. I also like to make another point. in U.S. Oncology recently, we're changing our pathways and our regimens. You don't need pegfilgrastim with Dosedense Taxol. People get bad back pain. The copays, may be difficult for patients. It's obviously costly. You don't need it. We did this big survey. There's not data there, but we did our big survey with people. We've all been using this for a long time now,
Right.
Most of us don't use it. So it really shouldn't be on our pathways, and it shouldn't be routinely used unless, of course, somebody has had already problems with AC or has comorbidities, of course. But so I would like to make that point. But I don't think FAC is dead.
Okay.
I think giving 200 per meter of adriamycin rather than 240 per meter is not unreasonable when we don't know that adriamycin is necessary, but we have a high-risk patient and we're not quite ready to not give the adriamycin. Now, in the triple negative, I want those DNA-damaging agents. I go with Dosedense ACT.
Okay. Why Dosedense? I understand versus Q3 weeks, but even in the neoadjuvant setting, a lot of these trials are based on weekly Taxol for 12 weeks, AC given every 3 weeks. You've jumped from the data from adjuvant into neoadjuvant.
Yes. So, the CLGB study that we heard at ASCO, looking at the every 2 weekly paclitaxel versus weekly, the randomized trial, showed basically no difference in outcome. The weekly Taxol was 16 weeks versus the Dosedense 4 treatments, or 6 treatments actually, it was 6 treatments, and the weekly had more, versus 4, I think it was 4, 4 Dosedense AC, there was more neuropathy in the
weekly for sure.
In the weekly, in the weekly for sure, and so with the 4 Dosedense Taxol, my impression is that there may be less neurotoxicity, but there isn't a therapeutic advantage of the weekly. So now there were a few more hypersensitivity reactions with the every 2 weekly, but those are very, very uncommon in terms of anything serious. So I didn't feel compelled to ask somebody to come in weekly.
Okay.
That it's a lot of time. So there's no therapeutic advantage at all of the weekly over the every 2 weekly. But actually, I know what it was. The Dosedense was 6 cycles. So you got to be very careful because there was a bit more neuropathy, I think, in the Dosedense, which is why it came out that maybe the weekly was the better way to go. That was kind of the consensus coming out, is that we should go with weekly instead of Dosedense. But it was.
But people aren't using 6 cycles. I
correct.
mean, that was just to make the times the same. Right.
So the neuropathy rates was 6. I don't think they really apply to our our every 4 4 cycles.
I guess theoretically, I viewed it that it takes a long time for these tumor cells to necrose and die off, and the PCR is what we're looking for, and sometimes expanding out these therapies over a little bit longer period of time may give the time for the tumors to die off and to see a PCR. Maybe I'm thinking wrong.
In the ER positives, I do exactly that, Christy.
Okay.
I give either FAC or AC preoperatively, followed by weekly paclitaxel because of that cell division.
Right.
But when you've got the full throttle triple negatives, I'd rather keep the Dosedense cycling. And the of course, in 9741, there was a nice delta. That was every 3 weekly, not every week, but there was a nice delta there. So I've equipoise. I've total equipoise on that.
All right. And then finally, this topic about the use of bisphosphonates in the adjuvant setting for patients. And boy, I thought this subject was dead. And of course, there's now a meta-analysis presented by Coleman from the Early Breast Cancer Trialist Group. That was presented yesterday. Do you want to highlight what they showed?
Very well done, very nicely presented, and you got the big guys involved from Oxford did a patient-level meta-analysis. 10 years follow-up, 18,000 patients received the bisphosphonates in the adjuvant setting, and the bottom line was that if you look at the postmenopausals, 55 years of age or older, so the definitively postmenopausal women, there was a 3.5% gain in 10-year distant recurrence in the bone, and this was highly statistically significant. no difference in non-bone recurrences, no help with the local regional, no help with the contralateral, but just bone recurrences, a definite improvement to 3.5% decreased risk. But it was only in the women 55 years of age or older. And so the hazard ratio was a 0.83, and that was so actually that was in mortality. That was mortality. So in the postmenopausal improvement, 3% improvement in overall survival, 0.83 hazard, 0.004, and
p-value.
P-value was 0.004, correct. It was so overall, putting it all together, a 34% reduction in bone recurrences, highly significant, and a 17% reduction in breast cancer deaths in your postmenopausal women, with all deaths also trending in that group in the right direction. So it wasn't that you were causing other deaths. So that was regardless of ER status, node status, plus minus use of chemotherapy, which he did not show those data, but he said that. Now, this was a meta-analysis where most patients got IV aminobisphosphonate, such as Zometa, zoledronic acid, and others got oral clodronate. Mm-hmm. And there was really no difference seen in the outcomes between oral. He made the point that we could not extrapolate these data to our oral weekly, residronates, et cetera. So that's probably, and oral weekly ibandronate. He basically is talking here in our country about zoledronic acid, mm-hmm. and it's every 6 months, because there was not an advantage that he showed for the Azure type, where you get it monthly times 6 months, and then every 3 months for the next 2 years, then every 6 months thereafter. So it was basically the twice a year, 4 milligrams, for the that was done in Z-Fast and Zofast, for example. He also made the point when asked that what about our patients in our clinics who have been on aromatase inhibitors year 2, 3, and would they be able to get this benefit? He said he did not think we should extrapolate the meta-analysis data to those patients, because patients who were in their late 40s, early 50s, who were perimenopausal, received chemotherapy, became postmenopausal, those patients did not benefit. So what he said is, it's where the cancer is at in the bone microenvironment, whether it's a high estrogen milieu or a low estrogen milieu, from the very first time they get that bisphosphonate, that matters. Now, in a woman who is already deeply postmenopausal, by the time she starts her chemotherapy and her AI, I'm not sure I see why he extrapolated from that perimenopausal situation. I get what he says there for that patient. That makes sense, mm-hmm. But if somebody were already over 55 and she got her chemotherapy and she went on to her AI and she's a couple years down the road and she's had that low environment, I guess what he's saying is that perhaps the benefits really occur on the very initial treatment, perhaps. But I guess
But that would be true of chemotherapy. I mean, we don't delay chemotherapy for 2 years because, if you're going to have an anti-tumor effect, you're going to want to do it as soon as possible before you are developing metastases with mutations and that sort of thing.
Yes.
I mean, I can understand, I guess, the lack of benefit in the delay. I think the point to me is that these were women who were in randomized trials asking the question about the benefit of bisphosphonate. This is not a look back on drug histories of women who were in randomized clinical trials to see if someone was on Fosamax or not. I mean, these really are trials of either clodronate, which we don't use in this country, or the IV bisphosphonates. And so I don't think we can extrapolate this to, my patient's on AI, I'm going to start them all on an oral bisphosphonate.
The other side, when we do know, if we bring in tamoxifen after a year or two, or in MA17, when patients were on placebo after TAM and then they got their letrozole later, they get the same benefit. Certainly it's a more conservative posture to say, do it like the clinic. If you want to get your benefit, do it like the clinical trials. But I can't really and I don't think we have data of late introduction of chemotherapy.
Right.
I don't think we do. Although we can say this, that if you're a stage 1 versus a stage 2, maybe you're a stage 2 because you were a little late on your MAM, you know, those screen versus non-screen, it's still the same relative risk reduction. So we're treating the stage 2 or 3 a little older cancers, you know what I'm saying? So we get the same relative risk reduction. So I don't really get it. You know, I don't get it. I actually think that if you've got an osteopenic patient, rather than use, you know, perhaps denosumab, which is FDA approved, you know, perhaps I can, you know, just instead of the reclass, which is once a year 5 milligrams, go to the twice a year 4 milligrams with a discussion with the patient. The issue is that it's not FDA approved.
Right.
We're going to need the NCCN to help us out here, and then I think we'll be able to, it's going to have to be guideline approved before we're going to be able to get coverage.
So I would say stay tuned for the publication of this meta-analysis, and then let's watch and see what NCCN does with it.
Yes,
to help us along.
We'll probably address that issue too, Christy.
Very good.
Yeah.
And then finally, just to bring in this point of IV bisphosphonates, there was just a trial that was presented by Gunther von Minkwitz around the use of zoledronic acid after patients had had neoadjuvant chemotherapy and an incomplete response or a lack of PCR, looking at the benefit of giving an IV bisphosphonate, called the Natan study. Just quickly, your thoughts about that trial.
Very simple trial. Folks received their preoperative chemotherapy, both ER positive, HER2 positive, and triple negative. This started in 2004, so I don't think the patients got trastuzumab. And if they were not a PAF-CR, they were randomized to the Azure schedule of IV zoledronic acid versus nothing. And the bottom line was, with 7 years follow-up now, no difference, 0 in disease-free or overall survival. However, if you look at the patients over 55 years of age, which was 34% of the population, their hazard ratio for recurrence was 0.87, which he said was just in 0.83. Beg your pardon, 0.83 was just in line with the Rob Coleman. And again, important to point out, very important, that the premenopausal patients did not have a deleterious effect either in the meta-analysis or in the Natan study. There's just no benefit. There was no detriment. But over age 55 in the Natan trial, there was a 0.83 with regard to disease-free survival. He did not break it down by bone recurrence versus not.
But the point is that the confidence intervals crossed 1. I mean, the numbers in this trial are just, to me, too small to really see whether in that group of patients they may have seen a difference of giving adjuvant bisphosphonate, IV bisphosphonate, in someone who got a lack of a PCR after neoadjuvant chemotherapy.
Yes, yeah. So it corroborates the Coleman study, and again, he didn't have the numbers, as you pointed out, to look in that over 55. What about the ER negative, you know, versus the ER positive, et cetera? But it certainly goes in the same direction as the. So again, we'll stay tuned for more a national discussion at the guideline level about this, and I think the issue is also going to be the ER negative population. Because Rob Coleman said regardless of ER status, like you said, we have to see the publication.
Right. So I think 2 big points for today: potentially practice confusion or changing. One is whether there's a benefit in the use of the platinum, specifically carboplatin, in the neoadjuvant setting for triple negative patients, and then how we're going to deal with IV bisphosphonates for our patients in the adjuvant setting. So thank you for joining me. I appreciate it, and I hope you enjoyed this interview with Dr. Joyce O'Shaughnessy from US Oncology, well known as a breast cancer thought leader in this country and internationally, and she spoke to me today at the 2013 San Antonio Breast Cancer Symposium on the topic of chemotherapy and triple negative. Please watch the other 3 interviews that I did while here at San Antonio, and there will also be an online monograph fleshing out some of these data in written form as well. And thank you very much.